Good morning, everybody. What a delight it is to be chairing this session this morning on psychological practice in physical healthcare. My name is Lucie Byrne-Davis, and I'm a professor of health psychology at the University of Manchester, and I'm also an HCPC registered health psychologist. I'm the current chair of the Division of Health Psychology of the British Psychological Society. So I have a couple of housekeeping items to start with today. Next slide, please. So we'd love to hear from you as the session goes ahead. So during the session, please post your questions in the Slido window on the right-hand side. If you have any technical issues today, can you contact the email address that is webcasting@firstsitemedia.co.uk. Please note that this session today is being recorded. So if you don't want your name to appear, please make sure that you're posting anonymously in the Slido. There'll be more information at the end of the session about where you can access the materials, your attendance certificates, and so on. We really hope you enjoy this session. Next slide, please. We've got a really fabulous agenda for you today. So we've got an excellent mix of experiences, thoughts, and really a lot of trailblazing that's happening in psychological practice applied to physical healthcare. I just want to spend a few moments with you first, really focusing on the breadth of psychological practice that's applied in healthcare or could be applied. There are hundreds of thousands of health professionals in the UK. For example, there's almost 600,000 nurses, just to mention one group. And GPs, in fact, have an average of 5 million consultations during their lifetime. So if these health professionals are insightful about their behaviours and mental processes and those of their patients and the public, and they apply those psychological principles to their work, relationships and the broader community, they could be having a huge impact on health. And this is what we call psychological literacy. So in addition to the fantastic psychologists and psychological professionals working in physical health, many psychological professionals work in universities with healthcare professionals, supporting them to take this psychological approach to their practice. Within the health psychology community, which I'll talk about specifically for a moment, we have people who work in a huge variety of ways in physical healthcare. And very excitingly, coming online actually in December, we've got some new health psychology trainees who are starting on a Health Education England funded pilot scheme. And this is really novel because it's training health psychologists to apply their expertise in behaviour change to a really tricky problem that we have in healthcare, which is the issue of health workers transforming their practice so that they can adopt new roles and practice in different ways. So 7 of these trainees will work across the regions of England over the next 2 years. And it's going to be very exciting to see this new type of application of psychological practice in healthcare. There's also a vibrant and impactful faculty of health psychology within the Division of Clinical Psychology. And there are many other psychological professions, as I've said, working in physical health and healthcare. And it's so exciting to be able to hear from some of those people today and some people who have lived experience of psychological practice in physical health. It really is high time that we, as psychological professionals working across England and the UK, pushed for services that reflect the truth that there is no health without mental health, and really tried to make a huge difference in that intersection between mental and physical healthcare, bringing those different forms of healthcare together in the best interests of our patients and the public. So without any further ado from me, I'd like to invite our first speakers today to introduce themselves and what they're going to talk about today. I hope you're looking forward to it as much as I am. Thank you.
Thank you, Lucie, and good morning, everybody. It's lovely to be here on our final day of PPN Conference Week. My name is Sunny Kalsy and I'm the chair of PPN Midlands, and I'm joined by two colleagues today. Would you like to introduce yourselves?
Hi, I'm Alison. I'm a service user with lived experience of complex mental health and physical health needs.
And my name's Terry. I'm a long-term carer.
Thank you both, and thank you for taking the time to join us today. For all of you out there, Terry and Ali and I met through a piece of work that was commissioned through the National Psychological Professionals Workforce Group, and that was around developing a programme and a report on psychological practice in physical healthcare. When this report was commissioned and it is going through an approvals process before people are asking where is it, one of the things that we were really keen was that the report captured the integral experiences of people who have actually experienced psychological practice in physical healthcare settings. So this morning's session is a conversational piece. It's thinking about the experiences that both Ali and Terry have had, thinking about what learning we can potentially offer to other people, individuals and families in similar circumstances, and also some learning for service providers as well, based on the experiences that Ali and Terry. Do you want to start sharing your experiences of actually understanding the needs for psychological healthcare?
If I try and give you a little bit of a sense of what's happened to me, my physical health and mental health have always been poor, but I had a really very distressing year where my health was failing, and that was both physical and mental, as I was trying to try and understand what was happening to me, but with no real understanding. And eventually, at a critical point, I was admitted to hospital, where I was diagnosed with a tumour. But I also was experiencing voice hearing. All my symptoms of complex post-traumatic disorder were present as well. And because of the immediacy of needing to focus on my physical health needs, my mental health needs were sort of pushed to one side because of the critical point that I was at with my physical health. I think really for me, at that point, I was in such a state of distress. I wasn't receiving support for my mental health distress. And I tried to take my own life at that point, and was transferred from the hospital to a mental health unit. It was a really, really difficult journey, obviously a very distressing one for my husband and carer and my family. But eventually I was discharged back home and to the care of a clinical psychologist who really helped me explore what had happened to me, and her input was really vital for all of us in how we manage day to day, to really get me to the point where I could be stable enough to actually receive the surgery that was going to be required for me to make a full recovery. Delays happened along that journey, but I was always supported by the clinical psychologist, and so was my family. Basically during that period, to try and help me plan ahead and navigate my distress, we developed a staying well plan, which was going to help me in hospital, and help the staff in hospital manage me with the presentations that I'd experienced. So the consultant was involved in that process too, and it really gave me a real sense that being in hospital next time would not be what had happened on the earlier occasion, because this planning had been in place. But unfortunately, when I was admitted for surgery, things started to unravel, and really that was the cause of huge distress. So I think maybe that's something that
from my side, I was familiar with Alison's fragile mental and physical health. and the impact of being told about the tumour was a particular sort of blow. And the fact that she had to go into hospital, it's something obviously I didn't want Alison to go into hospital, but knowing that this staying well plan had been produced, which was co-produced between Alison, her fantastic clinical psychologist, who was absolute anchor and has been an anchor throughout this time in Alison's life and on her health journey, that the staying well plan was put together, constructed, gave me at the time confidence that as much as we had that we could do had been done in preparation for Alison going in. So that would give both me, but particularly Alison, a measure of control entering what was basically an unknown situation.
And I suppose really for me, it was a huge sense that I had a tool, a sort of security blanket that was going to help me be an inpatient during this time. But it became very apparent very quickly that when I explained that I had voice hearing and was in a huge amount of psychological distress, that this very busy team who were overstretched and caring for many patients with complex physical needs really couldn't help me at that point. Also during COVID restrictions, I couldn't have any visitors. My clinical psychologist tried to get in contact with the ward, but wasn't allowed to speak to me because she was seen as being external to the process. So I really, really struggled. The staying well plan was really ignored by the staff, and really it was that disjoint in thinking about me as a person having experienced physical health problems and surgery, but actually with that presentation of voice hearing, I was perceived as being potentially a danger. I think that was a danger to other people on the ward, as well as maybe also to myself. So they used pieces of equipment to sort of basically put me in. So my bed space was surrounded by equipment, so I couldn't leave the space. And the other patients on the ward were told that I was potentially a danger. So that for me was also extremely distressing, that I couldn't explain my presentation because I was feeling so vulnerable post surgery, and so my needs were not being met.
Thank you both, and thank you for sharing with such honesty. Because I'm quite moved, and each time I hear Ali, you describe that experience, I feel quite moved that actually individuals like yourself, other people are experiencing what you experienced within a place which we would have hoped would be a place to keep you safe and to keep you well. I'm struck by a number of things that you've said, and I want to maybe talk us through this. One of the things that you talked about was the importance of you as a person, and within that setting, maybe you not being seen as a whole, as a person. Is that a fair reflection in terms of what it felt like for both of you?
I mean, from my side at the time, the two strongest emotions I was feeling was both frustration, because I would think it was almost unique for just a patient to go into hospital. That patient has a family, has friends, has maybe children, whoever it might be, have members who are really worried about that person. And as Alison's carer and husband, I was completely kept to the outside and not permitted any access at all, nor was I given any means to make anything happen. The fact that Alison's CP, clinical psychologist, was barred was just so frustrating. So that was a battle for me at the time. And so it's never was. I would say it's never just the one individual. There's a whole unit around it. And when somebody is at that low ebb of being physically lying in a bed post-operatively, and with also mental health challenges, and given also that the hierarchy in the hospital of strength of voices, shall I put it that way, you can feel that you have no voice.
And I think really for me, I have nothing but admiration for the staff who really are dealing with very complex surgeries. But by the same token, it had been discussed, and the consultant was involved in the planning of my surgery and knew about my mental health needs. But it was the actual ward staff who were so busy they didn't have the knowledge of mental health to be able to give me the support that I needed as a person, in extreme distress, trying to manage my isolation within an environment that was very scary because of what had happened to me on my previous hospital admission. And really, it was that kind of sense that, kind of they were doing their best to address my needs physically, but my needs, mental health needs, just couldn't be addressed or were misunderstood.
Thank you. I've got two more thoughts. I wonder, based on what you've shared and what you've experienced, what wisdom do you think you would want to impart to individuals or families in similar circumstances? And then my next question is, what learnings would you like to impart to people that are delivering services? But what are your thoughts? What wisdom would you like to share with individuals or families who may be in similar circumstances to how you found yourselves?
I think, in relation to what my previous answer, I would think from my side, better training in mental health for staff, and not just training at the outset, but training as a lifelong measure in mental health to run alongside the specialist knowledge that's required for surgery. So I think that's my key message, is really around managing an individual's distress by having better mental health knowledge, because that really is going to help that person not only have a better experience in their health journey in hospital, but also be better prepared to recover when they get home as well. Recovery is a long, slow process. So although I have my own perspective on why things went wrong, I do think that better training is required, and also potentially, even though this staying well document that we worked on before my admission didn't actually get used at the time, which was also part of the problem, because it gave many easy tips to manage my mental health presentations and what next to do if things started to escalate, but that was not utilised. But I do think, when I came home, while I was recovering my CP, and I worked on a new document, because we became aware that that isn't the end of my health journey, as it isn't for so many people. As the years go by, I will need more treatment, and emergencies happen. So we actually got together and we did a new document, a sort of staying well advanced statement document, which is now my go-to. It has been disseminated across all physical healthcare provisions that I use to be able to help me in the future. But I'm sure that Terry's got.
Yeah, I mean, I think there's kind of two questions in what you were saying there, Sunny. One is there any advice we might be able to give or share with somebody who's contemplating going into hospital in the imminent future? And secondly, we can look sort of more longer term. But in terms of somebody who is faced with going into hospital, I would say very strongly that if you have a period of time before that happens, use it. and use it by speaking to everybody you can in the hospital before you go into the person goes into the hospital, whether you are the advocate for that individual or whether it's at the actual patient themselves, and be totally brutally honest. There's no point in trying to conceal something which, if it manifests whilst you're in hospital, can be a cause of problems and distress. So speak to if you can the people on the ward, if you know which ward you're going to. Certainly speak to the consultant and the team around them. There will be a team associated with them. And if somebody has mental health issues, then identify and speak to the psychiatric element, the support team within that hospital, to prepare people as much as possible. The Staying Well plan was and remains a very good idea. It didn't happen in the case of Alison. It didn't work initially, but that doesn't mean that you shouldn't actively try to do it, because it also focuses people's minds. The team, for example, focuses people's minds on what they will be encountering when you, as a patient, goes into hospital. So speak to as many people as you can, make them aware of what your situation is, what the history of your presentations has been, how they may manifest themselves in hospital, because a hospital, for many people, for many patients, I would suggest, is an alien environment. And as I touched on before, when that process has actually started and you are in hospital, post-operatively, lying on that bed, nobody around you, it's unlikely that you will be a really good advocate for yourself. And you need as many steps prepared prior to that happening as you can.
And just to say, it's all healthcare should be psychological.
Thank you for that. I'm wondering whether or not you think there is any more advice that you would give for individuals who maybe struggle with advocating, because I think one of the challenges that we've got is a range of people will access healthcare. They will be experiencing all sorts of challenges in their own personal lives in addition to their physical healthcare. Have you got any thoughts about how they can be supported to advocate for psychological needs in physical healthcare?
I think certainly from speaking to the psychiatric team within the hospital, they are the people in situ at the time, and they may well act on your behalf and represent you and help you in that case. Certainly speak to the nurses. The nursing staff in the hospitals are just absolutely wonderful. No question about that. But also, there's no question that they are seriously overstretched. And there's an element that Alison touched upon, which we may move on to, about training. But anybody you can, who you either friend, colleague, family member, bring them involved from as soon a point as possible to help.
Thank you.
And I would say the same thing too.
Thank you both. We've got the final few minutes, so we've talked a lot about the learnings that we think would be really important, and training has come up time and time again, but not just a one-off training, but actually a constancy in the training of individuals in their appreciation of the intersectionality of psychological needs alongside physical healthcare needs. Is there any other learnings that you would want people delivering services to take away from our conversation today?
I think there is one thing which is slightly to one side, but it is back to all that preparation that could be done prior to being admitted to hospital. And that's to make sure that the processes leading into that link up better the psychological support that you have outside with the service that you receive once you're in hospital. I think that would be a really good bridge to both help staff manage to anticipate when things may be escalating as they did for me or going wrong. But it's that joined up aspects of, kind of where somebody is outside of the loop because they're not actually within the hospital, but they are working for the NHS. So it's actually making sure that those avenues of communication are opened up to allow better opportunities for that particular service user to navigate their surgery and their mental health at the same time, which, as I say, in my case, it was very divided, and that caused me a lot of distress, and it caused my husband and family a lot of distress. So I think that's another thing, is just making sure that communication is really allowed between and better facilitated between external and internal health services.
From my perspective, I think there's two aims, two goals. One is to achieve a better experience, both for the patient and the friends and family around that patient, and also to achieve better outcomes. And it's made me, the experience of what we went through has made me a passionate advocate of integrating psychological care therapy into the main physical healthcare system, because things have to change. It's as simple as that. Things have to change. It's just not, doesn't work at the moment. And how do you achieve change? Well, change needs to be both top down and bottom up. In terms of top down, as Alison's touched on, it's got to be implemented through better training and also better system organisation and better system provision. From bottom up, patients need to have a more present voice in terms of what's happening within the hospital. So those two things need to be happening at the same time to achieve a change, a systemic change, but really a change in people's mindset, which is the toughest ask of all. But just because it won't happen overnight, and just because it will take time, that's no reason not to start making as much move as we can now towards a healthcare system that sees people primarily, formally, totally upfront as people that have a level of health, and that level of health will encompass both physical health and mental health considerations, but looking at people holistically.
Thank you. And on that note, I don't think there's anything more that I can add. I've appreciated getting to know you. I've appreciated the generosity that you've both had in sharing your experiences and your advice. And I know that you're going to be joining us for the Q&A later on. But thank you, Ali. Thank you, Terry. Lucie, back over to you.
Thank you, Sunny.
Goodness, what a way to start. Such a huge thank you to you, Sunny, and particularly to Terry and Alison, who gave their time and expertise to support this session. And I think what was really powerful is that you not only shared your experiences, but also the important reflections that you've had on how things can improve. So you're really helping us move forward in our understanding of this really important topic. On quite a personal note, Alison's comment that all healthcare should be psychological really struck a chord with me. One of my roles is I'm responsible for the psychological teaching and learning of medical students at the University of Manchester. And I felt a fire in my belly when you were talking today, to think about what we're doing in our education of medical students and what we could be doing better. So I'm hoping that I might be able to have a longer conversation with you at some stage. But it's really, what a brilliant way to start. Thank you so much for all of you giving your time this morning. Right, I'm going to move us on. Our next speaker's coming now, and I'm going to let him introduce himself and his topic without any further ado. Thank you.
Great. Thank you so much, Lucie, and thanks, Sunny, Terry and Alison, for a really powerful start to the session. And thanks to everyone who's organised this session this morning. I'm Leo Russell. I'm a clinical psychologist and the clinical lead for the FND Psychology Service at Devon Partnership NHS Trust, which is part of the wider clinical health, psychology and neuropsychology department. And although it's me that you're being subjected to this morning, I'm really part of a much wider team of people who've been working on this. And in particular, I want to mention my psychology colleagues who've been hugely influential on this pathway. Phil Yates, who is the strategic lead for the wider department, Rachel Carrick, who has been working on the F&D psychology service in partnership with me since I joined, and Annika Amwako, who was with our team until very recently before moving on to Pastors New. So I just want to begin by putting a bit of context to our work on this pathway, which is really in the over the last decade with a mandate to break down barriers to physical and mental health care between those systems. One of the responses from our trust was for psychological clinicians in our clinical health and neuropsychology department, as well as colleagues from IAPT and psych liaison teams, to work together to look at developing integrated psychological medicine pathways, where we were working with long-term health conditions that might otherwise fall in this gap between physical and mental health services. So this just gives you a sense about what this looks like. And as you can see here, I've identified some of the pathways where people can often fall in the gap. And this is by no means an exhaustive list. And essentially what we've tried to do across various pathways is integrate care across primary, secondary, specialist services, social care, and the acute physical health trust. And to do this, we've looked at seeing where we can develop step care pathways so that people can have steps depending on the complexity of their need. And importantly, that this is also a matched care process so that people get the right treatment at the right time. And as has been emphasized in the previous presentation, that people can have coherent care plans throughout their experience and coherent narratives around their health. So I'm going to talk to you today about the FND pathway we developed. And for those of you who aren't familiar with FND, this is functional neurological disorder. And this is a neurological condition which is characterized by symptoms such as seizures, weakness, paralysis, loss of speech, tremors, and none of which are caused by brain injury or brain disease, but by a much more complex relationship between the mind and the body. So this process for us began in our community neuropsychology service, where Phil Yates and my predecessor, Ann Turner, undertook an audit of referrals that were coming through to our service and identified that, in fact, we were already receiving a lot of referrals for people with FND. So they decided to dedicate a small resource from within that service specifically for developing expertise around FND and to see people who are suffering with FND in an FND clinic. And over subsequent years, this gave us the opportunity to work in collaboration with our neurology colleagues and our neuro rehab colleagues to look at developing shared expertise and experience and to trial some new initiatives together, which included actually setting up a couple of conferences to share with colleagues in the hospital to try and raise the profile of FND more broadly. And this process itself led to the emergence of a core group of interdisciplinary staff across the mental health and the acute trust who were interested in improving care for FND. And on the back of this, we developed a virtual FND multidisciplinary team, which as psychology, we were able to facilitate and chair this space. But it was an opportunity for a group of professionals across the mental health and acute services to come together. So this included representation, as I say, from psychology, but also from physiotherapy, occupational therapy, speech and language therapy, neurology, psychiatry, social care, and more recently from nursing too, which has been great. And the model which we then evolved over time has the core premise really that the assessment and treatment of FND should be part of the core business of acute and community services, which means that for most people with FND, they should be able to access care locally without having to be referred out to specialist centres in other regions and out of their area. So in order to do this, we recognised this required a multidisciplinary approach so that we could capture patients presenting at different parts of the healthcare system, so that we could develop coherent care plans for people through their healthcare experience, and so that we could disseminate a full range of FND knowledge across the healthcare structures, and really develop a wider culture of understanding around FND rather than just have the understanding in one place. So this is the pathway that evolved over these conversations across the multidisciplinary team. And as you can see, patients present with neurological symptoms either through their GP or through the emergency department or acute admission. And one of the things that we put in place from the beginning was that it was important for all patients to have the experience of a thorough diagnosis through neurology, which means that not only were other conditions able to be ruled out, but also FND was specifically able to be ruled in. So looking for positive signs of FND rather than just assuming that it's FND when other causes aren't found. And then from that place, patients were able to be referred on to our FND community treatment pathway, which we've developed over time. And as you can see there, that includes referral onto FND psychology, but also possibly onto community rehab services, where as psychological professionals, we provide consultation and supervision to support them in that work. But a real key aspect in this pathway has been the complex case multidisciplinary team meeting, which, as I say, we've chaired through psychology. And what we do is we meet twice a month and we facilitate conversations where colleagues from across healthcare can present cases of people who have perhaps particularly they might have comorbid difficulties, they might have difficulty engaging with their diagnosis. It may just not be clear where they might go on the treatment pathway or what the best approach would be. So in these meetings, we discuss those cases as a team, we discuss those people, and we think with the clinicians about what might be good solutions to help that person. And we also use this experience to further think about how we can enhance the pathway and improve over time. So I'm pretty sure if I share the pathway with you in 5 years' time, hopefully it'll be different in ways which we can't yet anticipate. So the second half of that multidisciplinary meeting is about governance and enhancing the pathway. So in terms of the treatment pathway, by working together over time and thinking about different people's experiences, we've been able to develop some rules of thumb over frontline approaches, but also with all presentations of FND, what we do is we have the capacity to work together or sequentially if required. So in terms of psychology, we find that this is a really good frontline approach for people with functional symptoms or non-epileptic attack disorders, functional seizures. So when people get referred into our service, our offering includes an initial assessment with psychoeducation and a holistic formulation. And then some of the folks who come through our service might be offered brief intervention and consultation. Some of them may be offered an online program, which is supported by a clinician, which is based on ACT principles, so acceptance and commitment therapy, to help people live alongside their symptoms. And then we have a psychotherapy offering, which is focused on improving the symptoms where we can. And for this offering, we include therapies which address unconscious processes, so in particular, intensive short-term dynamic psychotherapy and EMDR. But we also offer some therapies which address more explicit cognitive processes, such as cognitive analytic therapy and compassion-focused therapy. So just briefly before I finish, we have had a look at some of the outcomes from this pathway over time. One thing we've done is we've looked at some single cases in terms of health economics. And here at the top is an example of a lady who we were working with who had suffered terribly from non-epileptic seizures and was having to access regular ambulance care. And then following 6 consultation sessions, this led to a significant recovery and savings of over £30,000 1 year post-treatment. So as you can imagine, if we're treating 100 to 120 people, even on conservative savings, this helps us to make the case to the healthcare services that value for money, hopefully. And then next, we undertook a case series study evaluating our psychotherapy option with ISTDP, and we were pleased to find that in less than 12 sessions, this was leading to significant improvement in well-being and quality of life, but also in the physical symptoms themselves, which was crucial, we feel. And then finally, there's just an example here of a joint initiative which we undertook with our physiotherapy colleagues. We had a physio join us for half a day a week in our service, focusing on people who are at risk of admission to the hospital. And over a 6-month period, we were able to have, in fact, 100% success rate of preventing admission, leading to significant savings, again, of around 24,000 over just 6 months. So finally, just to share some brief reflections here. Integrated psychological medicine approach is not just about integrating physical and mental health services, but actually integrating all services involved in health and social care, as Alison said, making all care psychological, hopefully. That we found the best tool for developing a pathway and improving our work was to have regular meetings with multiple professionals and stakeholders, including colleagues from FND Friends, the charity, and that this enabled us to learn from our previous experiences and to enhance the pathway over time so that it was a robust pathway. And I guess that would be my final point, that we feel that it's important not to wait until funding's been secured to work together to develop pathways for long-term health conditions and functional symptoms. And then once you get some momentum, it makes it easier to perhaps then make the case to commissioners for the benefit of the work together. So thanks very much for your time. I hope you found that interesting. And I'll finish there.
Leo, thank you so much. What was brilliant in your session was really being able to hear about a service that's innovating and to see those psychological professionals and the multidisciplinary team really pushing to work across those traditional boundaries. Not only disciplinary, actually, I was thinking about those physical boundaries of, you're using a virtual MDT and services coming out to patients to sort of overcome those physical barriers to accessing care. And I feel like this reaching out into communities can really only benefit patients. So it's really good to see a very successful, positive example of that, and your reflections on how you've been able to achieve that. So thank you very much. I'd like to invite our next speaker to introduce themselves and their work. You're very welcome.
Hello everyone, thanks for having me here today. I'm delighted to be invited to present about some of the things we've been doing in Manchester Pain Service to improve our health outcomes and reduce inequalities, and also reflect a bit on how the different psychological professionals in our team might add into the melting pot of the pain service as a whole. And to thank my psychology colleagues, in particular, Zoe Malpas, Becca Lifford, Tanya Stephen and Kat Pollard for their brilliant innovations that you're going to hear about today. So I'll first talk briefly about 3 innovations within the outpatient team, so kind of service development, service evaluations, and a bit of research that we've been doing, and then 2 within our inpatient services. So firstly, in explaining a little bit about the pain psychology team in our Manchester Pain Service, we have a mixture of clinical, health and counselling psychologists. I'm a health psychologist in the service, and we also welcome trainee clinical counselling health psychologists and MSc health psychology students for placements, which are important parts of the projects I'm going to mention today. And in our team, we're part of a large Manchester Pain Service, a large integrated MDT a multidisciplinary team with doctors, specialist nurses, physiotherapists and psychologists in there. And we work with people across several hospital and community sites with acute pain and more longer term persistent pain, whilst in hospitals, inpatients, and coming to the hospital as visiting outpatients for clinics, and in those secondary care and tertiary care settings, as well as in our integrated community hospitals linked in with GP surgeries. And as you might expect, our core business of the psychology team, in line with guidelines, includes individual pain psychology assessment and specialist formulation. 2 offerings of a pain management program, which is the gold standard for pain management, group programs that incorporate psychology and physio strategies for people getting to meet each other who are living with long-term pain. Individual pain management therapy, a smaller subset of our work, and then lots of MDT working and advice to support, as Alison said, the idea that all healthcare should be psychological within our pain service. So how have we been innovating in the last few years? So one thing I wanted to mention to firstly was the development of compassion-focused therapy for pain, which has been very much led by our consultant psychologist, Dr. Zoe Malpas. And you may know CFT as a third wave therapy approach that was has kind of follows the Buddhist tradition that was developed by Paul Gilbert in response to kind of growing neuropsychological evidence that some of our psychological difficulties can be improved by reducing shame and self-criticism that is so prevalent in people struggling with their psychological health, and supporting the development of a more compassionate inner voice. So in pain, Zoe was one of the first in the country to really work in persistent pain and realise that those members of our population with persistent pain, some of them can have a formulation that involves them striving very hard, pushing past their pain, and whilst that might lead to lower disability in the short term, there can be quite high self-criticism, and over time can lead to lots more flare-ups where people are pushing through pain and then ending up in a big flare-up of pain. So our traditional pain management programs don't usually account for this drive-based striving, and compassion-focused therapy might offer an alternative approach to those folks. So since 2015, we've offered a compassion-focused therapy group program, in addition to our traditional offering, with weekly 3-hour group sessions integrating pain management and compassion-focused therapy principles. And Zoe's recent service evaluation of 117 people who've gone through our groups were suggesting really significant pre-post effects on depression and pain-related disability and anxiety and self-efficacy, which are things we measure in all of our interventions, as well as self-compassion skills. That's just been published in the British Journal of Pain. And then, like many other services during the pandemic, we've been trying to develop on our digital offering and resources. And just at the beginning of the pandemic, our lead physio was lucky enough to secure some funding for us to develop online pain management resources. We wanted to do those to really support our service users and connect with them, even when we couldn't physically be in the same space as them during the first lockdown. So we made 27 short videos covering concepts like demonstrating breathing techniques, key pain skills like pacing, gentle Pilates movements, relaxation, sleep hygiene, some of the kind of core skills for pain management, and pop them on our Trust YouTube channel. And we're really pleased that those have been viewed quite a lot and are used quite widely with by our psychological professional colleagues, such as our IAPT therapists who we support through specialist supervision, tell us that they're really useful for working with those clients with long-term conditions that they come across. So we're really pleased about that. And then in addition, that was mainly to support us developing online group pain management programs during the pandemic, and we made our intensive version and our community version rotate to online. And last summer, our MSc Health Psychology students conducted a really lovely mixed methods evaluation, which looks like we were receiving similar health outcomes from these teams-based programs and positive feedback, adding to accessibility to people who perhaps weren't able to travel, weren't able to afford to travel, but do have a mobile phone or a tablet to be able to join. And they were really enjoying the chance to sit on their own comfy chair at home whilst joining in on the programme. Obviously, there's people who cannot benefit from that, and we're really mindful about that, but we have been continuing both offerings, including adding flexibility into the evening with our options to kind of expand our ability to be accessible to a wide range of people. And then our trainee health psychologist is currently piloting a shorter version, 6 hours, of an introduction to pain management program, because we know there's several service users coming through every month who can't manage to make our main offerings, either of our quite high commitment offerings, but we really want to kind of expand what we are able to offer. So we're doing a bit of feasibility work there as well. However, we know that those taking up our group programs, which is our main offering, tend to be more likely to be white and female than what we know about our full population in the Manchester pain service being a hugely diverse one. So as a small group of people who are interested, psychological professionals and physios who are interested in diversity and inclusion, we set about to explore some of our service users' views who are from Black, Asian or other ethnic minority backgrounds, who've been invited to attend one of our group programs, either the CFT or traditional pain management one, and either had or hadn't decided to take that up and finish it. And that work was led by our trainee counselling psychologist, who was Black British himself, who interviewed 5 of our service users in an in-depth way using interpretive phenomenological analysis. And that work's been really interesting, leading to really us understanding a lot more about what in our service could be some cultural adaptations to our programs and assessments, what information people might need that we aren't currently being able to offer them. And some of the key themes were about exploring important explorations within our assessments in terms of people's cultural views of pain and pain management, doing a better job of communicating what our offerings were and inviting questions, especially at the beginning of GP land, before the referrals even. Other ways of exploring how our staff groups and how our service users could be more reflective of the population, to help people feel more comfortable and reassured to come along to our group programs. So there was 10 recommendations in all, which we're currently taking forward and recently were able to publish. And then turning finally to the inpatient setting, where pain psychology has been part of guidelines for many years, but the roles are actually less described and less common than in, say, self-management teams in persistent pain. We're really keen to kind of work with our lead anaesthetist. He was very passionate about including psychology in his multidisciplinary team in one of the hospitals. And so led by Zoe Malpas, we were able to develop a role for psychologists in the inpatient pain team, both in supporting the multidisciplinary team working and ward rounds, and then offering brief, often just one session pain assessment and intervention, being able to link people in hospital out to outpatient and self-management support. And a bit like Leo, we were keen to look at the health economic impacts of this kind of work. So in our service evaluation, we compared a treatment group who did receive assessment and intervention from the psychologist with a control group who weren't able to receive that. And we found really positive outcomes on hospital admissions and lengths of stay, which our paper reported on, and I understand from working with different colleagues in the country that several new posts for psychologists have sprung up in the last year or two, which is really lovely to hear that was able to be evidence in a helpful way. So last, a little bit of research in the inpatient setting that we've been working on over the last few years. Total knee replacements, very common operation, but up to 30% of people don't have positive physical health outcomes and aren't satisfied with their treatment. And there is evidence to say that pre-surgery depression, anxiety, and worst case scenario thinking about pain, really expecting the worst, pain catastrophizing, can be predictive of poorer clinical outcomes. And we did an audit to start with of our patients and found similar things, that those pre-surgery experiences were common and led to poorer outcomes. And so over the last couple of years, we've been getting ready to develop a Be Ready pre-rehabilitation group psychology, very brief intervention, only 3 sessions, to help people with their mood, their anxiety, their expectations before surgery, to hopefully improve their surgery outcomes afterwards. And we are really excited to be starting out that feasibility testing in the next couple of months, finally, after a delay from COVID. So just reflecting then to finish on the diversity and in psychological professions and the melting pot of our pain team. At the moment, we only have psychologists and trainees. We don't have other psychological professionals, but we work closely with them. And each of our psychologists has, of course, different pre-qualification training, like health, clinical, counselling, psychology, but also bring their own unique experiences. I have more of a research background. Zoe has a neuropsychology background. Becca's worked in mental health, for instance, and Tanya's worked in paediatrics quite a lot. So we all bring our diverse experience as unique professionals on our career journey, as well as our family or division of psychology. And that feels a real strength. We feel we've got complementary skills, and we can offer different parts of our pain team different aspects. So, for example, working on the suicide prevention pathway, or developing our team's motivational interviewing skills. And that diversity also helps us think in different ways and work more preventatively in some ways, ultimately aiming to help improve our health outcomes and reduce health inequalities through our psychological approaches. So thank you very much, and here's some references below.
Thank you, Eleanor. Really interesting to hear about the push to reduce health inequalities, which, as we know, are growing rather than shrinking. And really interesting to hear about your really evidence-based approach that's kind of embedding that high-quality research into practice, so that understandings are created and then fed directly back into the services. So thank you very much. I'd like to invite our next speaker to introduce themselves and their project.
Thank you. Hello, everyone. My name's Miranda Budd, and I'm a psychologist working within Lancashire South Cumbria NHS Trust. And in fact, I just need to start by saying my internet is popping in and out, so hopefully I'll be able to stay with you for this presentation, and we'll make it to the end. But if I do freeze, I'll imagine Lucie might come back in. Okay, so I'm just going to talk a little bit about a new psychological workforce initiative known as the Trainee Associate Psychological Practitioners, or for short, the TAPS or APS, who are working, some of which are working in general practice settings with a focus on population health. Okay, so just to set the scene a little bit, really, a brief overview of primary care networks, or PCNs for short, in case those aren't aware of this information. A PCN is generally a group of general practices, a group of GP surgeries, and there's approximately 5 practices in each PCN, with an average patient list size of about 50,000 people. In Lancashire South Cumbria, the biggest we've got is 10 GP practices, with about 90,000 people who they look after. So they do vary in sizes, but broadly speaking, the average is about 50,000. And there's been, I guess, general practice feels like a really exciting place to be working at the minute for psychological professionals. There's been lots of changes to try and meet the demands or ambitions of the NHS long-term plan around creating more care in the community, trying to create more psychological care within the NHS. And as part of that, we have in PCN settings additional funding in the form of additional reimbursement roles, or you may have heard them as being called RS roles. And there's a variety of roles, including pharmacists, but one of those roles is a mental health practitioner. So mental health practitioner is an umbrella term for a range of mental health people who work in mental health. So that might be registered mental health nurses, but it also could be psychological professionals or OTs, for example. And in theory, by March 2023, so next year, PCNs can have up to 3 mental health practitioners working within their PCN, so across the whole of that PCN. And I say in theory because I guess PCNs have really struggled to recruit even one mental health practitioner at times. And it's potentially caused some workforce issues, as it generally, when a nurse or RMN comes to join as a mental health practitioner, it's quite likely they've hopped over from the local secondary care team. So it leaves a gap elsewhere. So there's been some problems. But I guess there's a real growth in general practice at the minute around the behaviour change workforce. So that includes social prescribers, health and wellbeing coaches, so that where they have managed to recruit, it feels like there is that behaviour change workforce team coming together to help focus on wellbeing and emotional wellbeing in that community and general practice setting. So it feels really good. So one thing we've tried to do in Lancashire, South Cumbria and in the wider northwest regions now is create a new workforce supply of TAPs or APs, these trainee associate psychological practitioners, to try and meet this rising demand from services and rising need for mental health care. So TAPs or APs are psychology graduates, to put it briefly, psychology graduates who want to come into the NHS to practice in the field of psychological healthcare. Now, I'm sure many of us know that it can be quite a competitive field to get into, and every year we lose a lot of talent, a lot of psychology graduates who want to get into the NHS but just aren't able to because there isn't the roles there. And so we take psychology graduates and it's the Health Innovation Agency North West Coast, Health Education England, Northwest and UCLan work together to train up the psychology graduates in a postgraduate diploma, and they work as a Band 4 TAP when they're in training and studying 1 day a week alongside being 4 days a week in clinical practice, and then Band 5 when they qualify as an app. So here you can see we had a lot of TAPs or APs coming into primary care settings. So cohort 1 ran January 2021 to January 2022, and we had 50 roles, 25 of which came into primary care settings. Cohort 2 are currently training at the minute, and they qualify March next year. And out of those 91 roles, 51 went into primary care, and that was across Lancashire, South Cumbria, Cheshire and Mersey, and the Greater Manchester region. So we spread in the second cohort into the 3 ICS areas, and there's a little map there on the right of where those TAPs and APs are based across the PCN settings in Lancashire, South Cumbria, which are the ones who I work a little more closely with. So just thinking then, in terms of what TAPs and APs in Lancashire, South Cumbria PCNs are doing, and it's varying in the different ICS areas, but we've got our service delivery model there on the right. And I guess we see ourselves as providing a mental health prevention and promotion service. So we do brief interventions, sit below IAPT, and there's a range of work. They do targeted work for people who've been referred to them, and then there's a universal approach as well, which I'll talk a little bit about. So we say we have to mirror that service of what general practice offers. So we offer an all-age service where the TAPs and APs are, of course, the most appropriate person or professional to meet presenting need. So, for example, if someone, a worried parent, were to come in with a young child, then they would be referred into CAMS because we wouldn't be the most appropriate person to meet need. But potentially there might be some brief intervention work we may do with mum or dad there. Their focus generally is on general referrals. So they take from general practice staff, it might be GPs, nurses or pharmacists or dietitians. And some PCNs, I guess one thing I've learned is the PCNs all work very differently, and it's best to see them all as individual services. some PCNs have asked that their TAP or app have a population health management focus, and they want to particularly work on reducing health inequalities around frailty or adolescence, or those newly diagnosed with diabetes, for example. So I can think of a recent example where a TAP was working with someone who'd been recently diagnosed with diabetes, and the GP had asked or advised that individual to go to a weight management program and prescribed some medication for them. But the person didn't want to go to the weight management program or want to take the medication. And so there was a room for a link psychological intervention there, because the person didn't want to attend the weight management program because they were anxious about their appearance. So the TAP helped do some work with that and help do some adjustment work around taking medication as well. So it feels like there's real opportunity to meet psychological need within that general practice settings. I think we find as well there's quite a lot of unmet need in general practice settings that's perhaps not picked up maybe in a 10-minute brief GP appointment. So we might get a referral for stress, for example, and then in that longer 45-minute appointment with a TAP or app, it's quite clear that that person needs referring potentially into IAP settings or secondary care settings. They do the group work as well. So we've had some good examples when they've worked alongside other behaviour change workforce colleagues, such as Social Prescriber, and helped, I can think of a recent group a TAP ran, helped older adults who were still struggling after, a group of older adults who were still struggling after COVID with reduced social contact. And so the group, there was a need for the psychological need for the group, and Social Prescriber helped as well to help people come back together and meet new folks as well. Some of the apps are doing triage or assess and refer when they've worked in PCN for a year. So that's helping increase GP capacity. I think we find as well that most people with mild to moderate mental health difficulties come and see their GP between 3 and 5 times. That's what the research tells us. So we're helping increase GP capacity in that sense as well, because the GP can refer directly to the TAP or app for a brief intervention, and then we're monitoring healthcare usage after that. So really briefly then, our results so far, we have analysed our first year evaluation, had it published. You can see the reference at the bottom there, and that showed clinically and statistically reductions on measures of anxiety and depression. So that was the GAD and the PHQ. So they were administered at time 1, first session, after the 4th session, and then again at follow-up. And those results were maintained at follow-up, which was 4 to 6 weeks later. And there was clinically and statistically significant improvements on measures of resilience and well-being maintained at follow-up as well. We've just done our interim analysis from year 2, and those results continue to follow the same trend. I guess we want to build on that as well, and we applied for NIHR Research Patient Benefit, RFPB funding, to compare these results against a control group, and we've recently been granted that as well. So we just want to keep building on the mental health prevention promotion work that we're doing in general practice settings and build that evidence base. Okay, thank you.
Thank you so much. Really different kind of innovation there, actually, where you're solving lots of different issues at once, introducing more opportunities for people to work psychologically, plugging really crucial gaps that you've identified. And again, that really, striking combination of real robust research and development being within the service, which is what the Research for Patient Benefit strand is supposed to be all about. So absolutely fantastic. I think we'll all be watching with bated breath to see your results when that study's gone ahead. Thank you very much. And so moving on to our last but not least, final speaker of this session. Take it away.
Well, good morning, everyone, and thank you very much for inviting me to talk today. I'm Professor Prof. I'm a Professor of Evidence-Based Psychological Practice within CEDA, which is a clinical psychology and psychological therapies training program group within the University of Exeter. And I've worked on this presentation and worked over a couple of years with Dr. Alex Hamilton, who's a consultant in renal medicine, and Sam Strickland, who's a researcher. And this really is quite a nice extension from the previous talk, because fundamentally it's talking about developing a new role we need to start thinking outside the box, and to meet the demand, we need to start thinking about different psychological or psychosocial workforces, which can bring a range of different skills and competencies, but also come from a range of different backgrounds rather than just looking at the psychological background. So a lot of the extension, the current work looking at extending psychological practice into medical settings, has largely focused upon treating common mental health difficulties, or treating mental health difficulties, more severe and enduring, but to a lesser extent. However, what I'm seeking to do with this role is to think about things slightly differently. Think about how we can actually embed or integrate, but more fully embed a different type of psychosocial role rather than psychological solely within specific medical settings. And this can support, therefore, a range of different psychosocial competencies, which go outside of just treatment. And the idea is to fully embed this role as part of the multidisciplinary team within that specialism. And this comes from partly my experience. Clinically, I work within oral and maxillofacial surgery, and I'm actually fully embedded within oral and maxillofacial surgery. I would say my clinical lead is a surgeon, and that gives a very different perspective to how I work with the patients, rather than being a psychologist who actually comes from psychology, but almost comes in and out of the specialism. Now, this proposal actually links to work that was done by the Health Education England at the time up in the Northwest. And this is around an assistant practitioner workforce for mental health. And my focus is upon developing an assistant psychosocial practitioner, which gives a different flavour to the role. I would stress, I'm also on the expert advisory group for the IAP programme, so people often think what I'm talking about is a psychological role to deliver therapy. The assistant psychosocial practitioner role I'm advancing is not a sole psychological role, and it does not deliver psychological therapy. We already have a range of psychological professionals that do that, so what this role will do is, if it identifies that is where this workforce is needed, then it will signpost, it will support the patient accessing that group, and then that group of psychological practitioners will provide input that more overlaps with their competencies. This is applying a range of psychosocial competencies directly within the specialisms, and it's fully integrated. It's not attached to a medical specialism, which is the common model at the moment, although I'm aware other models are emerging. Now, this is, I stress, is a different workforce. It actually is building upon the Band 4 NHS Careers framework, and we're looking at moving into the apprenticeship models. There's a lot of apprenticeship, there's a lot of funding for health and medicine and psychological practice now through the apprenticeships. And that gives us the benefit in which we can start identifying a different workforce. Doesn't have to have a psychology background, doesn't have to have a psychology degree, or indeed doesn't need a psychology degree. This would be a 2-year foundation training program with the apprenticeship standards. There's core and specialist modules, which are tailored to the area of practice. So there's modules in psychological practice work generally. There's modules in communication skills and engagement building. There's modules in understanding different determinants of health. And then there's a wider group of modules which focus on professional practice, focus on and indeed targeting the specialism. I'm going to talk about the renal specialism. So there will be a module which is targeting and helping the role understand how to work within the renal specialism, understand different professionals within the renal specialism, and also get to understand some of the treatment and some of the physical characteristics of the renal specialism and patients. So when patients mention creatinine levels, the role will understand creatinine levels. If patients start to talk about eating bananas or avocados, the role will understand that is a difficulty, and that's a challenge for people with renal disease given potassium levels. So they'll be tuned in. This role is supervised through training by a trained mentor within practice. That would be a mentor within renal and within psychological practice. And this would be seek employment as trainees at band 2, 3 in their first year of training, progressing to band 3 in year 2. So we're talking about a different workforce, and we're talking about a workforce with a lower banding. And the benefits of that is and that allows more of this workforce to be employed with the current restrictions on funding, and potentially those restrictions will get worse as the NHS moves forward. So what I'm going to talk about is the assistant psychosocial practitioner, and I'm going to use the example of the renal specialism. But that's just an example, because over time, hopefully, people may come with their apprenticeships and say, I would like this embedded in head and neck, which is where I work clinically, or in diabetes, or in a range of different specialisms within secondary care. And this evaluation of the funding, the development of the competency framework, and the ongoing evaluation is both through Health Education England South West and through Kidney Care UK. So a lot of this role is linked to the current psychosocial health manifesto that Kidney Care UK have moved forwards, caring for people with kidney disease. And within their manifesto, there's a large focus on meeting psychosocial needs, not just psychological, but looking also at the social. We talk about holistic, but we can't think about holistic approaches unless we consider the psychosocial and how to support the social. There's a recognition that beneficial interventions can be delivered by a variety of health professionals. The recommendations arising from this document is that psychosocial care needs to be assessed, that psychosocial interventions are available that meet the level of need. And at some point, they may become psychological interventions if we're solely talking about the mental health aspects. And as has been mentioned previously, that psychosocial needs need to be integrated into care plans. We can't just focus on the medical, or indeed we can't just focus on the psychological. We need to meet in the middle. And we also have to have a way of the different parts of the system meeting up. Earlier on, we had a very touching talk, and it identified how the patient often gets lost in the system. So part of this role will be to integrate, in this case, renal specialism, psychology, counselling, social work and psychiatry within the multidisciplinary team that works within the renal specialism. Now, the first part of what we did was to put together the competency map. It's very important that if we're going to invest in workforces, we need to know what appropriate competencies are for that workforce. And we went through an extensive consultation process involving renal patients, involving the National Kidney Patient Forum, involving consultants in renal medicine, social work, psychology, clinical psychology, therapists, psychological practice, so on and so forth, to get a holistic idea of what competencies they were felt to fit in and need. And we have the range of competencies under the knowledge and the values, under the core skills, the relational skills. It's very important to be able to build relationships. The skills using a range of psychologically informed approaches and also supporting people in areas such as self-management. But then we have also got to think about the self-care for this workforce, and then the meta competencies, them understanding their practice so they can carry on with their continual professional development and move forwards. If we have access, and I'll give you links to this competency map and the competency frameworks, and I've got the link at the end of the slide, so we don't need to go into too much around this, but it is about supporting carers as well, supporting families, liaising with the community. The community have a lot of resources, and it's important to bridge that link and also into social care, because we know at the moment there's a deficit between the linkage between medicine, health, psychology, and the social care services. So the psychosocial competencies are to support self-management. There's lots of self-management approaches. We've heard about some self-management approaches, but it's about increasing awareness and supporting patients to use them. To administer brief screening measures on entry into renal, they use 2 brief screening measures, and if they identify distress that may require mental health input, then the role will liaise with the appropriate mental health specialists, whether that's in the Improving Access to Psychological Therapies program in the community for depression and anxiety, or if there's a more severe enduring, with liaison psychiatry in the first instance. So there's a lot of liaison with other professionals who have other competencies. There's maintaining supporting relationships with both the patients and the informal carers through relationship building skills. And we can't forget the informal carers, because they provide so much of the support. Support for patients is often not just provided within primary or secondary care, it's provided 24/7 outside of the healthcare system. There's an awareness of services, support for mental, renal difficulties, social care, voluntary, statutory and charitable sector. And that's a role in itself, understanding the availability of these groups, because a lot of professionals or a lot of patients aren't aware. I've mentioned about supporting informal caregivers, and there's a lot of work going on in this area, and I'm involved with a lot of work in this area, in particular with a group at Uppsala University in Sweden. Supporting families, digital interventions, and also we shouldn't forget the great amount of peer and informal caregivers groups that can coordinate support as well. So these are the psychosocial, not the mental health therapy competencies. A big part of this role is to stop the patient getting lost in the system. There's a lot goes on around the patient, but at present, I don't see a lot that can support the patient at the centre of the system, gets to know the patient, build relationships, understand some of their needs, and then they can support the patient actively through the multidisciplinary team, liaising with a range of allied health professionals, with health and social care, with the medical teams. This is where the advocacy, as was mentioned at the beginning of this group of presentations, was mentioned. We need an advocate, and I suggest this role becomes the advocate by the relationships that they build on when the person is receiving care. Part of what we're also doing is developing a range of interventions which are appropriate, which can be used on self-management approaches, can be used by the patient individually on their own, but with the support of this workforce. These are some of the approaches we're developing in renal, but indeed they can be used in, we can adapt them for other specialisms. So these are what we call indirect prevention. It recognises some of the difficulties that people may have, and it suggests tips to overcome those difficulties. They're based on CBT, cognitive behaviour therapy techniques, and it's focused on prevention. It's not focused on treatment. If someone needs treatment, they get referred to the psychological professional to provide the treatment. So we have a range of these techniques. For example, get on top of your worry with kidney disease, difficulties. So that identifies a way of managing your worries, whether that's through problem solving, or if they're hypothetical worries that have no solutions, how to park those and manage that and deal with those hypothetical worries. Challenges. There are massive implementation challenges and issues. Supervision. Who provides the supervision? Because there's psychological aspects of this role and there's more health professional aspects of this role, the psychosocial. So we need to think about supervision. And at the moment, we have two groups providing supervision, but it's a different type of supervision. Commissioning. At the moment, we have mental health commissioners, we have physical health commissioners. When we floated this role to both commissioning groups, both of them have said, this is the role for the other group. We need to think about the reorganisation of care. We're not just tinkering, but we need to take a step back and think about how to fully integrate collaborative care. And that may require a reorganisation. And the renal service at the Royal Devon and Exeter Hospital are looking at ways to do that. And that's partly stimulated through this role. How does the role identify with a team, and what team do they identify with? And also the resources and how to go about resourcing this role. There is a link there. The slides will be made available, and some of the resources are available on that slide, but also the competency frameworks. So thank you very much for your attention, and hopefully I've given you a different perspective on the psychological workforce, because I strongly advocate that the psychological workforce needs to at least help people engage with the wider workforce. That's the medical, the health, and the psychological. So thank you very much for your attention.
Thank you, and thanks to all of our speakers this morning. It's been an absolutely gripping session, so much so that it's actually run on into our Q&A slot. So we have around 5 minutes for Q&A. Hopefully all of our panel members are able to see the Slido, which has the comments that have been coming through. So I'm going to have to be ruthless and pick what I see as probably the most common theme that's coming through, the common themes that are coming through. First of all, there's lots of support for Alison's comment right at the beginning, which all of the speakers have picked up on, that about making all healthcare psychological. So thank you very much for that. One of the biggest issues that people seem to be talking about are concerns around the new roles. So I guess I'm particularly directing this at Miranda and Paul. People are worried about creating confusion, diluting the workforce, perhaps potentially some of these lower banded roles being too complicated given the competencies that you're asking for, and also about not having a route through from band 2 all the way up to band 8 without more education and training. So I don't know whether Miranda or Paul has some comments on that, because I'm sure these are issues that you've been thinking about as well.
First, we went through, so obviously the competency frameworks are there for people to look at outside of this session. But we went through an extensive consultation process with a range of professionals, including psychological, and they felt that these competencies could be done by this workforce, this more diverse workforce. But what we have to remember is the workforce will be also working under the guidance of more senior professionals, freeing those senior professionals to use their competencies where they're more needed. So it's not a fully independent workforce, it is working under that direction.
Thank you, Paul. Miranda?
I think one thing that comes to my mind is I always stand by that phrase of, if you always do what you've always done, you're always going to get what you've always got. And so I think it's just important sometimes to think a little bit differently. And it feels like in services there's a real need for psychological practitioners to practice in a psychological way at those, I'm going to call it middle banding kind of level. You don't always need a qualified psychologist. And I guess if we think, what we've had before now, it's potentially assistant psychologists. And that role sometimes is a great role. Sometimes it feels unfair for some assistant psychologists, some of the tasks or roles they get asked to do. Or you might have other professionals trained in psychological approaches, whether that be our nursing colleagues, OT colleagues. And that's one way of increasing psychological delivery or psychological interventions. But it just seems a shame, I guess, when the workforce, but the supply is challenging around different roles as well. You may want to train up a nurse, for example, to deliver psychological interventions, but not be able to recruit someone to be able to do that. So to have these thousands of psychology graduates finishing their undergrad every year and wanting to get into the psychological health in the NHS, it just feels like a good match between those two to be able to bring and train up, exactly like Paul says, as long as they're trained in the right competencies and supervised appropriately by a qualified psychological professional. I think there needs to be clear clinical leadership and understanding around this is what they can do and this is what they absolutely cannot do, because that's not safe. But yeah, it does feel like it's meeting a need for that kind of middle ground, if you like.
Thank you. Thanks both. I'm anxious that we've actually reached 11 o'clock and we've not given a chance to our panel to say anything else. I think given that we started with Terry and Alison, if it's not imposing on you too much, I wonder if we can finish with you. And I was going to ask this to the whole panel, but I'm going to direct this particularly to you. What is the one recommendation that you'd give to everybody listening to this session this morning about how we can improve the integration of mental and physical health care from your perspective?
I think that having listened to everybody else that's spoken this morning, to hear the richness of what's going on that I'm not necessarily aware of in terms of research and planning and ideas about how to take this journey to make all healthcare psychological has given me a real sense of hope for the future, that that this is a journey that other service users will not have to make like I did on my own. So I want to thank everybody who's spoken today, because that's really given me.
And I would echo all of that, but I would also say, I'm enthused by this morning's talk, but there's a lot to do. It's a long path, but that's no excuse not to do things. So we have to keep pushing, keep moving forward, keep changing and evolving, and focus on better experience for the patients, and that in itself will generate better outcomes.
Thank you both. I don't think we could finish on a better note than that. A huge thank you to everybody on the panel this morning. I'm now going to pass over to Gita and Adrian, who are going to take over and finish Psychological Professions Week.
Thank you so much, Lucie, and thanks for a fantastic session with the speakers. I think you've really illustrated this big frontier of psychological practice in physical healthcare and the potential for us to be doing more across that frontier. So a fantastic session. So I'm Whittington. I'm National Clinical Lead for Psychological Professions at NHS England and Health Education England. And Gita, do you want to introduce yourself?
Yep. So I'm Gita Bhutani, the National PPN Development Lead and also the co-chair of PPN England with Adrian.
Great. So it falls to Gita and I to close the week, and what a fantastic week it has been. It's just been very intensely inspiring, genuinely sort of given cause for hope, as well as set out, I think, some of the great potential in what we can offer as psychological professionals when we work together with the public and with policymakers. So it's been a great week. There is an opportunity to watch again and share all of the recordings from the week. I understand most of them are already up on the PPN website, and today's session will be shortly. So please do share details and encourage others to log in and access the sessions. I want to say a massive thank you. Thank you to everyone who's attended during this week. Thank you to everyone who's spoken, and thank you to everyone who's worked behind the scenes to make it happen. It's been such a rich week of both national and regional events. I think also what's been striking is many teams have taken up the sort of potential of Psychological Professions Week locally and run local events, or used the Psychological Professions Week to stimulate interest and demonstrate the value of psychological professions in their teams. In the national programme, we've looked at what next for the psychological professions, how experts by experience add value, the ways in which the PPNs offer something to us as professionals, but also the way in which we can offer something to the PPNs. We've focused in on equality and diversity issues, on progressing careers, perhaps in novel ways, in new roles, and today in progressing across this frontier of psychological practice in physical health. So I think all in all, it's been a fantastic demonstration of the value of the PPN as a community of practice, and how this is supporting this movement from the public and from policy alongside practitioners for a more psychological NHS. So I just want to recap onto the vision for the psychological professions, which we covered earlier in the week and has been a theme running through all of the sessions. So our vision to transform lives and communities by extending and embedding psychological knowledge and practice across the whole of health and care. I think this week has brought to life the ways in which professionals, the public and policymakers are working together to live these commitments. And how fantastic to see this in action. And of course, we want these commitments to come down to earth. They're not sort of just planets up in the stratosphere somewhere, but these need to be lived in order to demonstrate our value. And coming next year will be our Intergalactic Bridge page on the PPN website. Please look out for this. This will contain a whole host of resources that demonstrate how psychological professionals are living these commitments and making this contribution real. So just before I hand over, oh, sorry, Gita, there was a slide missing, which thrown me slightly. So just before I hand over to Gita, I just want to say thank you again to the whole team who worked behind the scenes, and everyone who's presented, convened sessions, the steering group for the week. Behind the scenes, just to particularly pick out Jaislyn Stoneham, who's been programme manager for the week, and Kimberly Blakemore, who has been project officer, both of whom have sort of really supported and enabled the week to happen, but many others too. I've got a list of about 30 people who have been involved in one way or another behind the scenes, as well as contributing to the sessions. So thank you all very much. I'll hand over to you now, Gita.
Thanks, Adrian. So just to echo my thanks to everyone for what's been an absolutely fantastic week. But I think I just wanted to finish today was to basically say, please do join the Psychological Professions Network. We have psychological professions networks in all parts of England, and you can see a map of England with the different regions, because we map onto NHS England and Health Education England arrangements, which is perhaps why the map's colour-coded as it is. But basically, whether you're in the north, the south, the southeast, the southwest, or in London, do consider joining one of the PPNs. So how do you do that? That's the website address. All you need to do is click on that link and then find the tab that says register and fill in your details, choose your local PPN. And I think just to remind people, you don't have to be a psychological professional. You can be someone who has an interest in the psychological workforce. You can be a member of staff in the NHS or social care that's interested. You can be an expert by experience, or you can just be interested. So do join us. And I think with that, thank you very much.